Good afternoon and evening, everyone. A very warm welcome to this official launch of the newest Resolve Global Health Special Report on the path to universal healthcare coverage. That's a collaboration between Amgen, and this is a special report that we're publishing today. My name is Mette Thorngard, and I'm the Managing Director for Resolve Global Health, which is a journalistic platform that is providing actionable insights and impactful conversations to how we build more equitable healthcare systems for all. Today, on Universal Healthcare Coverage Day, we want to take stock on how far we have come within actually ensuring equitable access to healthcare for everyone. And I do think it's fair to say that we still have a lot of work to do. If we think of that roughly half of the world's population is still lacking access to very essential healthcare services, we also see that out-of-pocket expenses keep rising, and still is pushing people into poverty. Many families is only one disease away from bankruptcy. So also considering that we are in a time of crisis, that being climate, conflict, and geopolitical shifts, it is even more urgent for us to really now discuss how we can advance UHC. In the special report that we're launching today, we're looking at this path towards UHC. We cover both financial, social, and political barriers to why UHC is still not achieved, with a specific focus on NYCs. This includes both covering disparities in healthcare, innovations in financing, workforce development, the role of NCDs, new innovation, and much more. One of the absolute core red threads throughout the report, which we will share in a link shortly in the chat, is really the importance of collective action. So that's also why we in the Resolve Global Health team, together with our partner Amgen, is very excited today to have this conversation on UHC Day on how we can advance UHC. So let me just take you through what we are going to do today. We will be kickstarted by some introductory remarks by Sean LeBron in a second from Amgen. And then we'll spend most of the part talking through or have a panel conversation that will kickstart us through a conversation on many of the different issues and many different barriers that keep us away from UHC. We are very lucky to have Anders Nordström, who comes with a deep expertise in global health, including in his past role as acting director of WHO, to be moderating the conversation today. Thank you so much, Anders, for taking us through today. We will also have a Q&A session, so do remember to engage. Do remember to ask your questions. I'll come back to more on the housekeeping notes on how to do that. And we will also end the session on a conversation on what's next. So we have Juno Shrestha from the International Agency for Prevention of Blindness, who will also take us a little bit forward toward our next special report on rare diseases. So back on the housekeeping elements, this is a place where we really want to have engagement. So please, please do not hesitate to either write down your questions. You can do that in the Q&A chat. Or if you prefer to share your comments or questions verbally, please also do that in the Q&A session. Use the raise hand function before you unmute, just so we're sure that everyone can hear your question. And Anders will take care as well of moderating that part of the conversation. So before I hand over to you, Anders, I want to start by thanking Amgen for the long-term partnership in terms of really putting spotlight on some of the most critical health issues that we have today, including UHC. I therefore want to pass the word first to Sean LeBron, Executive Director and Strategic Lead of the Access to Healthcare Unit at Amgen, to kick us off. Over to you, Sean.
Super. Thank you, Mette, and I very much appreciate the attendance of the audience today. Just to note, so as mentioned, I work for and proudly work for Amgen, which is a biopharmaceutical company that focuses on area of high unmet medical need, including cancer, rare disease, inflammation, and cardiovascular. And for those of you who know Amgen will also know that many of the countries in which we operate are those in which universal health coverage exists. My team, as Meta mentioned, focuses on low and middle income countries in which we don't have a presence, and we very much focus on health system strengthening actions, on health education, and on being able to support NGOs who are working in the space to be able to support their actions. So Amgen's really pleased to collaborate with Resolve Global Health on this series of special reports that address key issues that impact access to healthcare. In the words of Resolve themselves, and this is one of the things that really drew me to the support, this is a platform for insights, conversations, and solutions to what's holding us back collectively from building healthier societies. The Resolve platform allows for a long format journalistic framing of key issues that relate to the theme, and importantly, the opinion pieces that are in here invite commentary from experts in the field to provide their perspectives. These, of course, aren't meant to be comprehensive reports that delve into all of the evidence for particular report themes. There is much a way to stimulate conversation and allow those who are in the arena to share their voice. Meta noted this, but in general, they're unashamedly focused on healthcare gaps or opportunities in low and middle income countries, where the disparities in global health are generally the highest. And today's discussion, of course, is focused on universal health coverage. And we particularly chose this to launch on Universal Health Coverage Day. I'd otherwise like to say Happy Universal Health Coverage Day, but it's a sad fact for the majority of people globally that they don't have access to universal health coverage or often even basic healthcare services. You'll note in one of the opinion pieces that only 11% of countries will have adopted a concrete strategy to have UHC by 2030. And this is precisely one of the reasons that we wanted to frame a report on UHC with Resolve, to be a part of this bigger conversation and to bring views into the open that address a range of humanistic, personal, gender and environmental issues that LMICs are facing in their journey towards improved health coverage. Personally, I strongly and fervently believe that health is a fundamental human right, but for many, many people, accessing healthcare is actually a privilege. If you can't pick from my accent, I'm Australian. So my personal experience is growing up and working for many years in a system that provides access to a wide range of health services at low or no cost, including subsidised doctor visits, specialist services and public hospital care. It's not a perfect system, but it is really great, in my opinion, and it's largely funded by taxpayer contributions, but also increasingly by supplementary health insurance. It's regulated and it's legislated, and it also has provisions for people who might fall through the cracks on affordability. Many countries don't have that. The journey to UHC for low and middle income countries doesn't immediately have to adopt those systems that high income countries have in place. They, of course, have evolved over many years. They weren't born the way they are, and they've gone through many political cycles, changes of government, through health emergencies, as we know recently, as well as budget crises. But the fact is that they all started somewhere. And for the 80% of countries that are yet to have UHC, it's a journey that obviously starts with which parts of the system are amenable to adoption of parts of UHC. So I'd like to end this by thanking you all for attending, for the writers and the opinion providers for the report, which is now available online, as Meta noted, and for all of the speakers today. We look forward to hearing your voices and those of the audience in the Q&A. So I'd like to now hand to Anders Nordstrom to moderate the discussion. Thank you very much, Anders.
No, thank you very much, Sean. And I'm with you from another countries where we are benefiting from universal health coverage, which is Sweden. There are, I would say, countries also in low and middle income settings where one are making progress towards UHC today. So I think it's not just that there are obstacles and challenges, there are also very good examples. But what we will speak about now during the next half an hour are some of the barriers, but also talking about some of the opportunities for how to address equity gaps, how to address financing, how to address or benefit from innovations, collaborations, and policy change, and the importance of political leadership here. And I'm delighted to have three colleagues with me that will illustrate and share with you both some perspectives and some ideas in terms of what we can do to move towards universal coverage in all countries across the world. So first I have Dr. Sarfraz from Women in the Liver. She's the Global Director for Gender. Delighted to have you with us. Then we have Herb Riband, who is the director for Access Accelerated, with us as well. Great to have you with us, Herb. And then finally, we have Justin Nonbinjong, who is the technical director for primary healthcare at Management Science for Health, presently based in the US. So 3 colleagues with slightly different perspectives and entry points to universal health coverage. So I hope by the 4 of us, we can have a conversation that the rest of the attendants will be able to benefit and to get some inspiration from. I would like to start with you, Dr. Sarfraz. I will come to your background in Pakistan. That's a country that I've been following quite closely for different reasons. But you are today working for women in global health. So the first question is, how important are gender barriers in order for countries to be able to achieve universal health coverage?
Thank you so much for the question. I would like to start by mapping the universal health coverage landscape a little. UHC aspires to provide equal access to healthcare for the world's 8.1 billion plus people, of which almost 50% are women and girls. Yet this aspiration remains far from reality for half the population, as gender-specific barriers persist, undermining their access to essential healthcare. Let's confront some of the troubling realities. Women and girls globally are dying from preventable causes during pregnancy, childbirth, and unsafe abortion. They are being robbed of autonomy over their health decisions. Yet, in high-level policy rooms, where I've often been the only woman, this rarely seems to be a priority. 225 million women lack access to contraception, and this leads to 60 million unintended pregnancies annually. Every 2 minutes, a woman dies from pregnancy-related causes. Clearly, we are not doing enough. Women are 73% more likely than men to sustain serious injuries in car crashes. Why? Because automotive companies primarily use male crash dummies for safety testing. We know, and it has been widely debated, the Gender Health Gap report, and in that report it stated that in USA, 30% of the gender health gap is contributed by a high burden of cardiovascular diseases among women. Yet there's such little research which addresses this disparity.
Yeah. No, please. I just wanted to hear a little bit also in terms of your perspective in terms of what we can do about this situation. How can we overcome those barriers? Because they are clearly recognized by, I would say, many people across the world. But what are your advice in terms of us overcoming the barriers?
In my experience, and some of the constraints for which, which are behind these barriers, the first one that I see is that 70% of the world's health workforce are women. Yet we see only 25% in holding leadership roles. And as I say that, we need to bring more women into policy rooms and decision-making roles to shape inclusive health systems. Again, there is, when we look at the distribution of this health workforce in high-income countries with just 16% of the global population, and that's what I was elaborating in the landscape, 56% of the world's health workers are catering to the 16% of the global population. Whereas when we look at Africa, where 25% of the global disease burden exists, only 3% of the global health workforce is available. This is a stark inequity in healthcare resources. We need to prioritize gender-responsive UHC by using gender-disaggregated data to guide these policies. And we need to invest in resources and funding so that there's accessible healthcare services for women, particularly in underserved and conflict-hit areas. It's important for us to track progress and measure the impact of the UHC programs on women's health so that we are seeing progress being made. The future depends on our actions today. The future of UHC is in taking up a disaggregated and a granular approach using this data.
A lot depends then on political leadership. And as I was saying initially, you're coming from Pakistan. I saw a colleague of you here in Stockholm just yesterday, Sanya Nishtiar, who also was a strong force in Pakistan for some years now. She's leading Gavi. But what's your experience from Pakistan? I mean, how can one actually get the interest and the traction with the political leadership for those changes that are needed?
During my tenure, as I was leading the Pakistan social sector portfolio for the Prime Minister, I saw firsthand how health systems are deeply interconnected with socioeconomic indicators such as poverty, education, gender, equality, and employment. These links are universal, and addressing them requires strong political leadership and comprehensive structural reforms. For Pakistan, where the health budget is constrained to 1.2%, and we have a population size of over 250 million, it is very challenging to achieve UHC. But I think the story is similar across the globe, particularly for low middle income countries. We do have some interesting examples of how the political leadership championed UHC as Pakistan's leadership addressed the lack of affordability for transport services as a bottleneck for accessing free EMOC services at the basic health units. And this introduction of an ambulance network supported by existing lady health workers in underserved communities helped us improve and address the maternal and neonatal mortality rates in a province of over 120 million. So we have such examples of political ownership in Thailand also, where they reduce the out-of-pocket health expenditure to ensure health equity for its population. And I think Pakistan's example of owning its lady health workers, the community health workers, who are a very essential pillar for UHC, is
and
very
also
critical.
that is something that could be an entry point for the broader package of universal health coverage and the need for that. That is politically also possible to communicate, and it's also politically quite attractive to make a political priority. I mean, I follow that and I find that a very interesting example. Should we move? We come back to you, but if we move to justice, I mean, you are working for Management Science for Health. One of the key things is, of course, it's not just political decision. You need money as well. So from your perspective, what are the most, or your experiences, effective strategies to raise the necessary resources for universal health coverage? Can you say something about the financing? How can we change the way that we finance basically health service to reach universal health coverage?
I think what is very important.
No, I'd like to move on. No, sorry, Dr. Arafat. I will come back to you. Now to justice, please.
Okay.
Now to Dr. Justice, please.
Yeah, thank you very much, Anders. I'm happy to be on this panel. So when we talk about financing, it's important to place this in perspective. There are different estimates showing that countries, especially in the African region, will require there's a UHC financing gap essentially of between $176 to $371 billion annually. Depending on which source you quote. And when we talk about sustainable financing, I am one who believes that it's important to start from within, because my understanding of sustainability is one's ability not to keep asking and begging people, but one's ability to sort of have a longer term solution to the problem. And so I always look to domestic financing. I mean, I acknowledge the caveats and the challenges around debt sustainability and all of that, but just putting it in context. Now, Africa is a continent that has a GDP, and I was looking at estimates, IMF estimates this morning, of close to $3 trillion for 2024, projected $2.8 trillion. What portion of that, if we pick the lower end of 176 billion financing gap, it's about 6.3% of GDP. The continental GDP, of course, that there are differences, and of course, if you pick countries that are fragile, that are conflict affected, the situation is different. If you pick the high end, 3.71 billion financing gap, that's 13.3%. On average, what are our countries spending on GDP on health out of GDP? It's somewhere around 5%, 6% on average. So tell me that if we got countries, it's part of all the challenges to say move up, domestic financing, and I'm talking about publicly funded, social programs and health programs, not so much of out-of-pocket payments, which themselves are inequitable. So tell me that we cannot significantly ramp up domestic financing of UHC from the public coffers with all the caveats. Of course, there are caveats around debt sustainability, but there are also caveats around tax to GDP ratio, how much countries are able to raise, which is relatively low in Africa because we keep burdening the same people with taxes, and the vast majority of the people, are not mainly paying direct taxes. So the point I'm making is that yes, all sources of financing are important. Donor sources are very important. But when we talk about sustainability in financing fees, UHC, how do we see financing UHC in the future sustainable? We cannot rule out domestic financing. And the last one,
can I ask you more specifically about that? Because as you say, 5% of GDP in low-income countries, middle-income countries, in high-income countries, it's close to 10%. So, I mean, is it possible then to increase the spending in low and middle-income countries? And as we heard from Sean when he started speaking about Australia, and the situation is the same in Sweden, that we pay basically our healthcare from our tax bill. And you say that it's the same people that are basically being taxed, that are paying tax. I'm not sure that might be true, but there's quite a few people that do not pay tax, and quite a few companies that do not pay tax. I know in Nigeria, the burden of taxation there is about 17% or something. In Sweden, it's 48%. So can one then, what will it take politically to increase the taxes, not just from the ones that are paying a lot today, but the people that are not, and the companies that are not paying today? How do you see that from a political point of view?
Well, Anders, thanks for that, but I respectfully disagree that the same people do not pay tax. I mean, I take my salary when I was at the University of Ghana, where I had been for 15 years. Yeah. Direct income tax from me alone was about 30%, right? When I said the same people pay tax, what I meant was that the formal sector, which pays direct taxes to government, is small. The informal sector is so large. Yeah. So except for taxes that people pay, VAT on goods and services and stuff like that, the large majority of people do not necessarily pay taxes from salaries, for instance. Of course, there are the organizations, and we know, the politics involved in paying. So, if you look at some of the Afrobarometer surveys that have been made, Africans are not generally, against taxes. What they're actually against, or what they're interested in, is what the taxes are used for. But the point I'm making is that, granted that you actually keep the tax burden, the rate of tax on the people paying the same, if we can increase the efficiency of tax collection through the
the point I was trying to make is not that you should pay more, but other people could pay more, and some companies could also pay more in some of the countries. If you talk about Africa,
obviously we have a huge part of our GDP in Africa driven by a few things. I mean, minerals, oil, gold, and all of that. And a lot of the companies, do not, well, I won't say they do not pay tax, but the level of tax, essentially what the country could get from these companies, the country is not getting. So we require the political leadership. But the point I was making is that, finally, Anders, is that we've seen that for many of our countries, social health insurance has been for them, a way that government commits to financing health in the longer term because it's protected by law. And I think, bearing all the challenges there are, these are ways that we could actually get governments to commit a bit more of public financing for health. Over.
Very interesting. I think this is a top priority, really, to see how one can pursue this. But it takes political leadership. That's the bottom line. Another question, which is different, but I think it's interesting. Sometimes, and you were mentioning more efficient tax collections, but sometimes we're speaking about it's not just more money, but more efficiency gains. We can actually deliver more health services for less or for the same money. Is that possible at the same time as we're also moving towards better equity in access to health services?
That's an interesting question. Thanks for bringing that up. Efficiency simply means we implement strategies to ensure that we maximize output. So we need to prioritize, because many of our countries actually have very ambitious UHC roadmaps, practically wanting to implement everything, which is not possible. It's not feasible from their budget. So one needs to prioritize. Now, in prioritizing, there is the tendency to prioritize interventions such that you systematically leave out some important groups of the population. And that is where inequity comes in. And I think, for example, when we talk about selective PHC, we talk about focusing on specific, priority diseases. Chances are that while you do that, you are likely to leave out the maybe not a majority, but a certain group of population with specific characteristics that are very important. So the point is that our countries will need to institutionalize the ways we make decisions about prioritization, and equity is one of the key things that we look out for when we do prioritization, so that we ensure the decisions we are making are not systematically leaving out a certain group of the population. So yes, equity, it is possible that as we focus on efficiency, we leave out equity, but it needs to be built into the prioritization system such that we minimize the extent to which we will do that.
Thank you very much. And most importantly, we need to speak about both things at the same time, not just one.
Right.
Very good.
Agreed.
Herb, you are coming from the private sector, and sometimes we see private sector as a little bit of a challenge or a problem when it comes to achieving universal health coverage. I don't personally, but I'd like to hear from you in terms of how you look upon the role of the private sector. Of course, you should make a profit and you should pay tax, and we spoke about taxes as important. But if you still look more in terms of the private sector when it comes to anything from service delivery to new technologies, it would be interesting to hear how you see that private sector more in general can contribute also to better access to health services for everyone.
Great. Thank you, Anders. In my view, to advance universal health coverage, we need an all-hands-on-deck approach that combines the best efforts and capabilities of both the public and private sectors, as well as civil society and multilateral organizations and others. And we also need to address non-communicable diseases, or NCDs. I would argue that access to quality NCD prevention and care is key to achieving UHC. The private sector, in my view, has demonstrated a commitment and capacity to drive solutions at scale, leveraging its resources, contacts, and know-how in various areas. And my organization, Access Accelerated, is a collective effort of innovative pharmaceutical companies. And I believe it's one model for how the private sector can partner to achieve both NCD outcomes and UHC in low middle income countries. Since 2017, Access Accelerated has worked with partners like the World Bank and leading NGOs to support over 40 projects in LMICs that advance UHC by expanding access to NCD services, improving care quality, and reducing financial hardship. And I fully agree with Justice that inadequate financing remains a major obstacle to further progress. In my view, maybe the most important area where we have not made sufficient progress. And to address this gap, Access Accelerated recently launched a new financing accelerator network for NCDs, or the FAN, via a technical partnership with the World Bank, collaborating with Results for Development and AFIDEP, the African Institute for Development Policy. And the aim is really to help LMIC governments and key stakeholders improve financing for NCDs, working in collaboration with experts like Justice. So there are many ways the private sector can and does contribute. I heard recently that the private sector is responsible for 50 to 70% of healthcare services in Africa. That may or may not be the right percentage, but I do believe the private sector can and should be a part of the solution. And this means, pharmaceutical companies, med tech, diagnostics, insurance, tech companies, logistics companies, we really need this all hands on deck approach.
I like to come back to the financing of NCDs because I think that's really interesting. Because the global health community basically has not focused on the NCDs this far. So and that's really the big burden of disease if you look across the world today. But in terms of new technologies, new drugs, etc., products, that is also increasing cost. And it can increase the gap in between the ones that can afford and the ones that can't afford. What are your perspectives in terms of what one can do from a private sector perspective, actually not to increase the equity gap or the gap in between people, but rather to try to make sure that as many as possible get access?
Yeah, well, I'd first start by saying in most LMICs, even older products are not getting to patients who need them on a timely, affordable basis. And I think it's 90% of the WHO essential medicines list are basically generic medicines. And most countries are not providing access in an appropriate way. So I think we need to look across the whole range of products, ranging from innovative to generics and biosimilars, and really think about access to quality care as a whole. I believe that access to products and access to quality healthcare go hand in hand. You can't really have one without the other. But certainly looking at new ways of financing products that are coming onto market, tiered pricing models, other things that have been used successfully during the COVID pandemic could be solutions going forward. But first, we need to, I think, do two things: increase the amount of resources available. And secondly, as was pointed out earlier, help countries to expend those resources in ways that achieve the greatest impact. And so using technologies, digital health solutions, there are ways that LMICs can be much more efficient than high-income countries. And I live in Switzerland, which has an excellent, well-funded healthcare system, but it's not very efficient. And I'm sure if we redesigned it from scratch, we could do things better.
I remember when I was in WHO, we were asked actually by Switzerland, WHO and OECD to take a look at the Swiss system and give our assessment. But I mean, also Justice, you are in the US, and I don't think we should speak about the US healthcare system when it comes to the cost. But I'd like to get back to Dr. Sarfraz. We've spoken about here the role of the importance of political leadership, the financing, but also the private sector. I'd just like to hear your reflections on what you have heard.
Yeah, I think picking it up from Justice and from my experience in Pakistan as I was leading the COVID-19 resource mobilization when I was at the Planning Commission, it's not only about low financing, because we were able to increase with the political ownership, putting up a very strong investment case with experts like Justice, a case which helped us increase the financing for healthcare by 410%. But it's not only the financing in low middle income countries, but it is the ability to efficiently and effectively utilize the resources within the government corridors. And I think also the suboptimal utilization of the private sector. So if I would look back and with that 410% of the additional financing going only to the government to lead the programs, there wasn't capacity to utilize that financing within the government offices. We needed more public-private partnerships to scale up our operations, really. And I would strongly agree that there are best practice models and there are things which the private sector can do, while the governments in the low middle income countries can come up with models of encouraging the private sector to invest and enhance reach using so many technologies that they had already invested in. We do not need to start from scratch with the government, taking the lead in there, but optimize what is available.
So how can you ensure, if you have a strong private sector in a country providing health services, that there is equal access in terms of quality, in terms of affordability for the whole population? What is needed then from the government side?
We need to have regulatory frameworks to encourage the private sector to come and invest. and their interests have to be safeguarded. But I mean, I think there is a need to have a more narrative showing the value that the private sector brings in. So I'll just share with you as an example, when I was doing an economic evaluation of the public health programs that a government institution was offering. And the stance was that they were offering free of cost programs and all. But when I did the cost analysis, I realized that what we were getting from that government institution was far more in terms of unit cost per student of if I would have sent them to John Hopkins or one of the leading institutions, you know. So it's very important for us to have those technical abilities built in, and they can come in from our partners. We had model, and we had a very strong working model during the time of COVID-19, where we worked very closely with the partners and with multilaterals and bilaterals, and using evidence, using their technical abilities to put up strong investment cases and work holistically on a One Health plan, rather than one coming from, you know, the in silos, coming from one sector, one coming from the one partner, and often there are overlaps and no synergies between these plans. And that is, I think, one of the challenges that we confront.
Justice, I mean, MSH, you're also quite involved in research, and I think you have an interest yourself in research. What can we benefit from research, understanding how health systems are working and how we can achieve UHC? Do we need research on that as well? Or do we have research around that as well that we can benefit from?
Yeah, thank you very much. I agree with all the colleagues have said. And I think that when it comes to evidence is a strong part of advocacy. You know, you cannot talk about financing when you are speaking only with the Ministry of Health, no? Because the Ministry of Finance is the one that, you know, to a large extent pays. And for them, you need to show the evidence. You need to show that, you know, if an amount of money is invested somewhere, whether in the private sector or through the public system, it generates, you know, not beyond the health outcomes. Yes, it generates some economic return, because that's the language they understand. So research is very important, not only, I mean, I spoke about financing, but I think across the system, what do you even prioritize? Which interventions, you know, are important? What criteria do you need? And I think what we need to do is to systematize, you know, the use of evidence from research to make decisions, because a lot of the decisions we make are mainly individualized. You know, if you have a health minister who is very open to evidence, then research is used. But we need to ensure that whoever is there, the system builds and picks from evidence. Our academic institutions in all of our countries have done fantastic job. And I can see your books behind you. You know, in our part, we say a lot of that evidence is in the shelves. And it's up to us, the public sector, to work with academic partners within the countries, but also from elsewhere, to pull together that evidence to help us make decisions that are efficient.
It's mainly novels behind me. There's not so much of scientific literature, but still, that is also a science in itself. But can you give some examples of research questions that are important if we would like to move towards UHC?
I'll give you one from Ghana, which is where I've done a lot of my work. You know, about 3 years ago, we realized that the health insurance scheme did not reimburse treatment of childhood cancers, even though the medicine or the drug, you know, the first line drug was already on the health insurance medicine list. But if a provider treated a child with cancer, it wasn't reimbursed. So what did we do? The ministry has a health technology assessment unit, and I worked with the technical team. We carved a research question around how efficient would it be? In other words, is it cost effective to use the same drugs approved to reimburse for childhood cancers? We did. Turned out it was very cost effective. What happened after that? About a year later, maybe even less, the government has incorporated the treatment of childhood cancers, and many more children with cancers can now go to the hospital and get care. This is one question that may have come up, from one person's mind of reviewing what is there. But I think the impact of this is lasting, because every child with cancer can now go to a facility and not worry so much about who pays for that treatment.
Great. Then let's come back then to Herb. As I said, one of your priorities and main focus in your work is the financing of NCDs. And I've been working on global health issues now for 30 years. It's been mainly focused on child and maternal mortality and AIDS, TB, and malaria. Very little attention on NCDs, even despite that is really the big burden of disease. Many countries now have a double burden, especially the low-income countries. So what is your approach? How should one tackle then that one needs to continue to finance some of the basic services that we have done, but you need also now to bring in much more financing for NCDs. How to do that in practice?
Yeah, well, we've got a lot of work to do. The current level of NCD financing in most countries is very low. So how do we propose to change that? We want to set up this network of regional NCD financing accelerators that will provide on-demand technical support, cross-country learning opportunities, and catalytic seed funding for programs aimed at improving NCD financing and health outcomes. And this is what AFIDEP is going to lead for us in sub-Saharan Africa, but later we will bring this approach with our learnings from Africa to Latin America and the Caribbean and the Asia Pacific regions. Here we want to provide, to a point Justice made earlier, countries with a menu of different potential financing solutions, including domestic resource mobilization, things like health taxes, innovative financing mechanisms, insurance schemes, development bank assistance, donor funding. There's a whole range of possibilities, and the idea would be for countries to pick from those based on their local needs and situations. So we want to have a very strong local engagement approach, listen to what countries need and find ways to help address those needs. And here we're very aligned with the World Bank, which has publicly announced a goal of delivering quality healthcare to 1.5 billion people by 2030. Yeah. So it's going to take some effort, Anders, you're right.
But
we cannot let up on infectious disease, but we can do a lot better on NCDs as part of universal health coverage.
Yeah. Brilliant. We have got 2 minutes left, so I'd like to hear 30 seconds from each of you. What is your wish for 2025? Your priority wish? Dr. Sarfraz first. What is one priority wish for next year when it comes to moving towards universal health coverage?
I wish to see more gender responsive programs being financed, being monitored, and being rolled out. We cannot forget the 50% of the population and continue to have the gender health gap.
Good. First, that's noted. Justice, what is your wish for next year?
My wish is to see more of our countries take more responsibility for financing their own health.
Yeah.
More of our countries take on the more responsibility, not share that responsibility, leadership or financing responsibility to external partners, but take responsibility themselves.
And Herb?
I want to see an expanding range of actions on the ground, meaning locally tailored financing models that really help countries improve health outcomes by addressing NCDs as part of strong UHC systems.
Thank you. I have a much smaller wish for next year. I wish I will see you in person and meet you again next year. So big thank you for this conversation. And now back to Mette. Over to you, Mette. Thank you.
Great. Thank you so much, both to our wonderful panelists and to you, Anders, for moderating this conversation. I'm wondering if there's anyone in the rest of the group here who wants to either put their hand up, ask a question. It can also be a remark. Anything you want to engage on, super helpful. Yes, please go ahead. If there's anything you'd rather put in the chat, you're also most welcome. But I wanted to take a minute to see if there's anyone who wanted to engage.
Questions, reactions? Yep, there we got one hand. Please.
Hi, thank you so much for the panel discussion. I thought it was super cool. So my question is for Dr. Surfaraz, because she mentioned that about like Pakistan. I'm originally from India, and I think my one like really big question was that, like you guys also mentioned taxation, but I was wondering how can countries in the global south sustainably be able to finance universal health coverage without overburdening the low income population, since a majority of these countries inculcate of that population, and it just seems like it seems to have a disproportionate effect, even if the target audience at the end of the day is them. Yeah, that was just like a little food for thought there. Thank you so much.
That was quite a big question, but an important question.
Yeah.
Dr. Sarfar, would you like to comment on that?
Yeah, I think for low middle income countries where the budgets are low and the asks are high, it's very important to create forums where we bring together all the partners, multilaterals, bilaterals, the governments, CSOs, and come up with one plan which is being which can be sourced through several financing routes. So what if we are funding something through the government funds, it should not be duplicated. We do not see synergies, and that is also due to ineffective coordination that is there, and the government has to play its role and the others as well. And I see that as a very important thing. And I think another important area is to use data to guide you to prioritize the investments, because we invested a lot in district and regional mappings and on the different indicators to pinpoint where the funds were needed the most. Because if you're going to fill in those gaps, the impact is going to be far more, rather than continuing to invest in areas which already are not that weak. So it's important to use data, go granular, and to help governments prioritize where the investments are needed.
And also, as somebody was mentioning, the out-of-pocket expenditures, that is huge in many countries, to find means and ways to bring that into a coordinated, organized system instead, and not allowing people to basically get ruined when they fall sick. That's another important. And many countries are trying now to also bring in not just the formal sector, but the informal sector into some sort of organized financing. Any other questions or comments from anyone else? Quiet audience.
There's a question in the chat
I don't
from
see
Tui.
the chat. Where is the chat?
I can read it out to
please
you.
read it. I don't see it.
So she says, thank you for this insightful discussion. We've heard about the need for political commitment and action to UHC. What role does civil society and public awareness also play in pushing for government leadership in health for all? Do I need to take it again?
The role of civil society, yes.
Yes, and public awareness.
Yeah. Who would like to reflect on that? Now I see the question as well. Please. Herb, please.
Yeah, I was going to say, I think the role of civil society is critical. These are organizations that represent people and communities. They represent voters. They have a lot of expertise in different areas. And that's why, my organization has partnered with a whole range of civil society organizations. And it's quite a powerful partnership when we work together. So I think it's fundamental. I think the theme of UHC Day today is really around governments and the work that they need to do. I think governments and politicians are responsive to the voices of voters and communities. And so civil society can really help bring a strong voice to help encourage governments to take the lead where they need to do so.
Perhaps one can also see that civil society plays both that role to be the advocates and also holding governments accountable, but also they are very important service providers in very many countries as well. So part of service delivery systems in countries, it varies of course from country to country, but civil society play a very important role here and are also contracted and partners to both international organizations and to governments. So the fabric here of governments, international organizations, private sector, business, and civil society and researchers I mean, that is what is needed in order for us to be able to move towards universal health coverage. I think we allow a few more minutes then, Mette, for the speaker to follow.
Absolutely. Wonderful. Thank you so much again for this wonderful conversation. And I think we've touched on a lot of very exciting topics. At least my takeaways are also relating to, again, what we want to look at today is like the path towards UHC. And for me, there was something very interesting comments in terms of how to bring women into leading roles in the healthcare sector. How do we look at prioritization from an equity perspective with the limited budgets? How do we look at inequity financing, both from a perspective of new innovative financing models, but also how do we improve the efficiency of the available financing? So I think we already today carved out a few pathways towards UHC. So super exciting. What I think is going to be most important is really how do we keep the momentum? There's civil society, but there are many other ways. So hopefully we can keep ourselves in this call accountable towards that going forward. Now, this is one collaboration we do in Resolve with partners like Amgen. We also work with other partners like the Leo Foundations and other wonderful partners. For the next, even though now we have UHC Day, we are also in the Resolve Global Health team looking forward for the next special report, which will be also collaboration with Amgen and also around a very interesting topic around rare diseases. So just to look a little bit ahead in that sense, we are today happy to have Juno Shrestha from the International Agency for Prevention of Blindness to speak a little bit more into this topic of rare diseases and what are some of the main issues around that. So handing over to you, Juno, please.
Thank you so much, Matt. And thank you so much for this opportunity today to speak at this very important event marking the launch of the results report on the path to universal health coverage. So IAPB, International Agency for the Prevention of Blindness, is the overarching alliance for the global eye health sector. So we have more than 250 member organizations in over 100 countries, and we are recognized as the global leader in eye health advocacy, coordinating major campaigns such as the World Sight Day and leading initiatives like the 2030 Insight, the UN Friends of Vision Group, Vision 2020, and the Vision for the Commonwealth. For example, we organized vision screening at UNICEF this year on the occasion of World Sight Day, marking the theme Children Love Your Eyes, and also at the United Nations office in New York. So IAPB has been at the forefront of global advocacy on eye health at the World Health Assembly and at the United Nations. Through our advocacy efforts, we have championed resolutions, the first ever eye health resolution at United Nations General Assembly, and few other resolutions at the World Health Assembly that integrate eye health into the universal health coverage and also the Sustainable Development Goals. So it's my absolute pleasure here to share about IAPB collaboration with Resolve and Amgen on the upcoming Resolve report, special report on rare diseases. So rare diseases like rare ocular conditions often remain undiagnosed or misdiagnosed for years, exacerbating patients' challenges and health inequities. So in 2023, we presented a statement, a constituency, a group statement at the World Health Assembly highlighting the impact of rare eye diseases on people and health systems. So I believe that the upcoming report will shine light on these critical issues, complementing today's report on universal health coverage, while also exploring on finding solutions through global advocacy and awareness. We need more solidarity and awareness both at political and community level. At IAPB, we are committed to support this effort through advocacy, fostering political will by mobilizing government, partners, and CSOs. So thank you again for this opportunity. IAPB is proud to stand alongside Resolve and all of you in this vital mission.
Thank you so much, Juno. That was super helpful. So please stay tuned. We are going to be launching the next special report as well on this topic. If you have interest in this, please reach out. We are still developing the content and the pieces, so you're also able to engage if you have an interest in that. As you can see, we are covering a lot of different topics. If you have an interest in a specific topic, please do reach out. We are more than happy to have new collaborations across many different sectors. With that in mind, I want to wish everyone a wonderful UHC day today. Thank you for your participation. From our perspective, we still very much have both a moral and for sure also an economic imperative to really work towards UHC as a core element to achieve equitable access to a quality healthcare for all. So thank you so much again for your participation. There will be links to the report in the chat, and also if you want to engage with our social media, feel free and go and read some of the articles. I think we have managed to cover some very exciting topics this time around. Thanks again, everyone. Giving you back a couple of minutes.
Thank you so much.
Thank you.
Thanks, everybody.
Bye.
Thank you.
Bye.
Thanks, everyone.
Bye.
Thank you. Bye-bye. Bye. Bye.